Hello everyone. This is a video recording for the peripheral nerve injury portion of Lab 5. Be on the lookout for another recording that will cover the rest of the content in that lab. But specifically for this video, we will talk about peripheral nerve injuries, their mechanisms, functional implications, as well as what we do as occupational therapists to address uh, people with this to work with people with this diagnosis. Um, from prior lectures, we understand that the upper motor neurons are nerves that are within the brain and the spinal cord, the central nervous system, right? And lower motor neurons are those nerves that are within the peripheral nervous system. So essentially, upper motor neurons come from the brain, extend and descend down to the spinal cord, and then the lower motor neurons connect to those upper motor neurons and then extend out of the spinal cord to the rest of the body. So peripheral neuropathies or peripheral nerve injuries are those injuries that affect the lower motor neurons. There are various mechanisms of injuries when it comes to peripheral nerves. Um, you know, car accidents, sports-related injuries, overstretched nerves, uh, compression. These are the different ways in which that these injuries can take place, right? And the type of injuries are compression, trauma, toxin-induced, infection-induced, vascular disorders, degenerative conditions, all affect the peripheral nervous system. Injuries to the peripheral nerves, they can lead to um, altered or loss of sensation, right? Diminished sensation or complete loss of sensation. And that has specific functional implications, right? So, for instance, and we'll talk a little bit more about it in future slides, but a person who has loss of sensation on their feet, their balance is going to be affected. A person who has loss of sensation in their hands, as we practiced in lab, right, stereognosis might be impacted. Their ability to maintain grasp of something may be impacted. Um, if they are unable to differentiate between hot and cold, right? So if they're cooking something, they're at a higher risk of burning their hands because they can't necessarily feel hot or cold sensations. Or so the various type of implications um, to loss of sensation. And dexterity can be impacted because of loss of sensation on the fingers. Um, there are some tropic changes that oftentimes occur with peripheral nerve injuries and consequent sensory loss, dry skin, hair loss, brittle finger, brittle fingernails, and these are not necessarily caused by the sensory loss, but it can certainly co-occur. Now, not just sensory loss, but also motor functions can be impacted because of peripheral nerve injuries. And these loss of motor capabilities or reduced motor capabilities certainly could, over time, lead to tightness that develop, that can joint stiffness that can develop, or tightness of the tendons. Posture and positioning can be impacted. And when it comes to the extremities, more particularly with the hands, motor loss can eventually lead to contractures if not properly managed. So it's very much important for a therapist, and we'll come into the specific treatments that are appropriate for different type of sensory and motor loss as a result to peripheral nerve injuries. But it's important for therapists to address um, any motor and sensory loss in a way that it doesn't lead to some of these long-lasting conditions or um, conditions like contractures and stiffness and all of that. All right, so there are different medical conditions that could lead to, or causes, I should say, that could lead to peripheral neuropathy. Now, peripheral neuropathy is it's a broader term that describes damage to the peripheral nervous system, and It essentially could involve one nerve or it can involve multiple nerves, right? So when multiple nerves are involved, it's called polyneuropathy. Um, it's important to understand the potential cause of this neuropathy. Um, Not just, well, particularly for understanding the medical management of it, but also the therapeutic approach as well. For instance, diabetic neuropathy is a peripheral nerve injury that people with diabetes oftentimes could experience, and it is associated with loss or reduced sensation of on the foot or the feet, and then of course pins and needles and things of that nature as well. Now, because of the nature of the the damage to the nerves and what causes it, um, this is not something that improves or gets better in time. So the medical management of it is going to essentially chronicle around uh, symptom management. And from a therapeutic standpoint, certainly there are different things that we would consider, right? For instance, a person with diabetic neuropathy, because of the loss of sensation in their feet, is likely going to experience poor balance or reduced balance, right? Because we rely on our sensory feedback in order to understand where our feet are, and that gives us information that is necessary for maintaining balance. So people with diabetic neuropathy are at a higher risk of falls. And so there's going to be a lot of therapeutic focus on educating in fall prevention. Um, in addition to that, because of the diminished and loss of sensation on the foot, it is going to be imperative that the person routinely checks their feet to make sure that there aren't any cuts or bruises that they are not aware of. So a lot of education towards skin check is going to be necessary. Proper footwear for injury prevention is going to be important as well. So that's going to, therapeutic approach essentially will focus on educating on the proper footwear. They are diabetic socks that people with diabetic neuropathy would benefit from, looser socks that are easier to put on. So those type of different things. So a lot of it is going to be about fall prevention, compensatory strategies for engagement in the ADL, IADL tasks, making sure that the person does routine skin checks and things of that nature. Now, when it comes to peripheral nerve injuries related to physical damage to the nerve, which certainly can occur with any type of trauma or injury or surgery, depending on the extent of the damage, there could potentially be nerve regrowing that could occur that essentially would lead to improvement, right? However, it's important to know that a nerve injury is a long, recovery or regrowth is a long process. It could take up to a year, even more. But the potentiality for recovery is there. So while we do a lot of education related to, and we'll come specifically into the treatments, but again, the potentiality for recovery is going to be there. Or other things that could be considered, not of course not by OTs, but by neurosurgery team, is whether or not a surgical intervention would be appropriate. There are autoimmune disorders as well that could lead to peripheral neuropathy, lupus, rheumatoid arthritis, Guillain-Barré, and things of that nature. Now, in these cases, recovery is likely as well with medical interventions to address the underlying cause, which by addressing the reducing the inflammatory process that is taking place. Different type of infusions, oral medications can be utilized for that. So therapy could essentially operate with the potential assumption, with the assumption that there's going to be a potential recovery that takes place. Um, Chemotherapy can also lead to peripheral neuropathy, and many times there could be some recovery once the medication has been discontinued. But in many cases, it's a long-term situation. So it might be a similar approach, right? Diabetic neuropathy, where we focus a lot more on compensatory strategies. This is the brachial plexus, and you all may have heard of the brachial plexus. It's essentially it's a network of nerves that originate from C5 to T1, and these nerves start off, they're the roots, then they kind of transition to or branch off to become the trunks, then the trunks divisions, the divisions cords, and the cords are branches, and these are the ones that kind of start to innervate different parts of the muscles. So this is a web of nerves that come again from those um, vertebrae and then extend out to innervate different parts of the muscles. Why is this important? Well, it's important because these nerves innervate essentially the entirety of the arm, right? The nerves that come from these regions innervate the entirety of the arm. And so damage to that area could be very devastating in terms of the function of the arm. Now, when we look at specific damage to specific nerves that come from the cervical and the spine, C5 through C6, nerves that come through this region are called the axillary nerves, and they innervate the deltoids, the anterior, posterior, and middle deltoids, as well as the teres minor. So what are the deltoids involved in terms of movement pattern, right? So the anterior deltoid helps with shoulder flexion, the middle deltoid helps with shoulder abduction, and then of course the posterior is involved in shoulder extension, right? The teres minor is a muscle in the back. I'm not going to go through the origin and the insertion part, but what the teres minor is involved in is external rotation, right? So a nerve in this, the nerves that come through these regions, the axillary nerve, if it is impacted, right, from the motor standpoint, it is those specific movements that will be affected, right? Shoulder flexion will be affected, abduction will be affected, external rotation will be affected, and then shoulder extension would be affected. Now, of course, the extent of the impact is going to depend heavily on the extent of the injury to the nerve. So what are some things that we would do in occupational therapy? It's important to do passive range of motion. Of course, our therapies are not going to be specifically focused on that and nothing but that, right? So we want to be able to do passive range of motion, but we want to be able to teach the person to do that on their own, or a caregiver or family member. When we do passive range of motion, the purpose of it is to prevent any tightness from taking place if there is a potentiality of recovery, and certainly improve circulation as well. It's important that when we do passive range of motion that we do it very judiciously, right? And so, for instance, if the person is not able to actively lift their arm and they can't get to 90 degrees, it's not advised to passively push the arm beyond 90 degrees flexion or abduction, right? So that could create some potential injury at the glenohumeral joint or the structures that are involved in that area. Now, that's passive range of motion. And that's from an exercise standpoint, passive range of motion. It's also important to talk about joint protections, right, to allow for the nerve to potentially heal. And from a joint protection standpoint, is just making sure that the arm is positioned appropriately, that it's not hanging to the side or hanging when the person is walking or standing for an extended period of time. So some sort of support, sling support may be appropriate, but not like one of those elbow slings. Maybe what's called the proximal support sling or a humeral cuff sling that hooks around the humerus, and then there's a strap that comes from the back and comes to the front. And just making sure that the person is not in any position where the arm is getting pulled. So those type of joint protection programs will be appropriate for the individual. NMES, neuromuscular electrostimulation, may be appropriate. An EMG could be done to determine the extent of the damage or to see if the pathway is intact. Edema prevention is going to be appropriate, making sure that when the person sits that the arm is positioned appropriately. When the person is lying down, that the arm is positioned in such a way that it's not hanging that is elevated slightly in order to reduce the chances of dependent edema from taking place. And dependent edema is where fluid accumulates in the distal part of the limb because the arm is hanging. If there is edema present, retrograde massage may be appropriate. When we're doing exercises or movement patterns, it might be good to start out with gravity reduced and then kind of, which is horizontal, and then go to vertical movement patterns where gravity is a challenge, right? All right, so now we talked about brachial plexus earlier and how these are the nerves that come from C5 to T1, and they consist of the roots, the trunks, the divisions, the cord, and the branches that extend out. Now, the brachial plexus, as we talked about earlier, the nerves innervate the entirety of the arm. So imagine if there is an injury to that, it is going to affect the entirety of the arm. And oftentimes brachial plexus injuries are unilateral. They do occur because of trauma like motor vehicle accidents, motorcycle accidents, sports injury. They can also occur with radiation therapy or chemotherapy. There is a condition called chemo-induced plexopathy. It is when the brachial nervous plexus is affected because of chemotherapy, and oftentimes that is a degenerative condition where it gets worse over time. The interventions for brachial plexus injury are similar as the axillary nerve injury, right? So we want to do passive range of motion to maintain joint flexibility. Of course, when we do passive range of motion, again, we are being careful and judicious to not cause any harm. Sometimes people with brachial nervous injury may have sensory impairment, they may have hypersensitivity or hyposensitivity. In the case of hypersensitivity, of course, desensitization is going to be an important approach. Weight bearing is good for proprioceptive input, proximal strengthening, as the person is able to do that, of course. Gravity minimized or reduced exercises to potentially against gravity exercises can be helpful as the person progresses. If of course, their progression is recovery is possible. Electrical stimulations can be helpful. We talked about slings earlier in order to make sure that the glenohumeral joint is the integrity is maintained. And in this case, of course, we do not want to use the traditional elbow slings, right? We want to use either the Givmore slings, and if you're not familiar with Givmore slings, it's a sling that gets applied distally on the hand and comes around the top of the shoulder and anchors on the non-affected side. And then, of course, the humeral cuff sling or the proximal support sling that I talked about earlier, the sling that comes around the top of the humerus and has two straps. One comes from the front and the other comes from the back. That allows for, again, the increased articulation of the glenohumeral joint in order to maintain its integrity. It's important to also consider potential use of splints to prevent contractures from taking place. And again, with any type of edema, retrograde massage would be helpful. And retrograde massage is where you gently apply pressure at the distal part of the limb, most particularly on the fingers, and then just gradually as pressing down and going up to essentially push the fluid up. From the edema standpoint, the key thing is to really prevent edema, and that is through positioning. All right, so the long thoracic nerve, and that's C5 through C7, the long thoracic nerve innervates the serratus anterior. The serratus anterior, that muscle, it helps with shoulder protraction, right? Scapular abduction and upward rotation, as well as stabilizing the scapula up against the back of the rib. Now, knowing that injury to the to this particular nerve certainly will affect the serratus anterior. So, but what we will see is reduced scapular abduction, right? Maybe scapular downward rotation, and maybe scapular winging. Now, in this case, um, uh, potentially nerve regeneration could occur. If it doesn't occur, surgery might be necessary to reduce the excessive mobility of the scapula. Um, we want to make sure that we utilize external support systems to stabilize the shoulder and limit the hypermobility of the scapula. Absolutely, I think this affects the arm function, and similar to the brachial plexus injury and the axillary nerve injury. And so, utilization of adaptive strategies and adaptive equipment for the person to engage in their day-to-day activities is going to be essential. All right, so we're going to take a look at a few tests, and, um, and we'll wrap it up for this. Now, the first test that's on the list is the Finkelstein test, and it is used to rule out or rule in decorvian tenosynovitis. Now, this is not a peripheral nerve injury. This is inflammation, decorvian tenosynovitis. It's an inflammation of the abductor pollicis longus and the extensor pollicis brevis. Those two muscles, not muscles, tendons, right? So they essentially come through the radial portion of the wrist, right? And so when there is an inflammation there, oftentimes people do experience pain there. Now, I'm going to digress a little bit, although this may not necessarily be appropriate for this lecture. But sometimes when people have osteoarthritis that affects the CMC joint of the thumb, they may also have a similar type of pain. But that's kind of that's assessed differently. For decorvian tenosynovitis, the Finkelstein test, essentially what you'll do, and you can watch the video as well, what you'll have the person do is support the forearm and have them actively ulnarly deviate the wrist and see if the pain is reproduced. If the pain is not reproduced, then you're going to take your hand, grab the palm at the radial side and push down and see if the pain is reproduced. If it's not, then you can take the thumb and tuck it in and push down and to see if that produces the pain. Now, again, this is not a peripheral nerve test per se. This is to determine whether or not there is inflammation of the tendons of those two muscles that I said earlier. Fallon's test is to determine whether or not carpal tunnel is an issue. Now, carpal tunnel is a peripheral nerve condition. It's an inflammation of the median nerve that passes through the carpal tunnel, right? And so the Fallon's test is where you have the person press their wrist together and hold that position for about a minute. And you want to see if there is any change in their sensory experience. Oftentimes, if there's carpal tunnel syndrome, they will experience pins and needles or shooting nerve type pain. And you want to see where the distribution is and whether or not the distribution is along the median nerve distribution. Tenosyne elbow, that's for checking to see if there's any inflammation or neuropathy along the ulnar nerve. Essentially, the ulnar nerve passes through here on the ulnar side, right? You can see. I don't know if you can see in this video. And so what you'll have the person do is bend the elbow and hold it and tap around at the side of the elbow where the ulnar nerve passes through. And if there is a neuropathy of the ulnar nerve, there should be some pain, familiar pain that is reproduced. All right, I think this is pretty much it for this lecture. Yep, this is pretty much it for this lecture. There will be another video for the rest of the PowerPoint content for Lab 5, and that will be uploaded soon. Alrighty, have a wonderful day, and we'll see you all next lab.